Hello, everyone. Welcome to our Common Hand Conditions virtual seminar today. Thank you for making your health a priority. My name is Kayla Meyer, and I'm a marketing specialist for Franciscan Health. To begin, I'd like to share a few housekeeping items. Everyone is muted upon entrance into this virtual event. We ask that you keep yourself muted to help us avoid background noise and interruption. If you have any questions you would like to ask during the presentation, please enter them into the chat window. We will address those questions after the presentation. Our awesome administrator, Kirsten, is taking care of everything on the back end. If you have any technical issues during our session, type your issue into the chat box and she will help you. If you miss anything, don't worry, we will send out the on-demand recording when it is available. If after the presentation you feel like you are ready to schedule an appointment, please let us know in the chat and you will receive priority scheduling. Before we get into the presentation, we'd like to understand a little about our audience. Let's start with a quick poll question. Our first question today is, what upper extremity body part are you or your loved one experiencing pain or discomfort in? Looks like a lot of you have been engaged, and almost everybody is having some discomfort or pain in their hands. So hopefully we're able to answer any questions that you have today and get your hands to feeling better. Our presentation today is given by our 3 orthopedic hand surgeons, Dr. Richard Makowicz, Dr. Tony Lin, and Dr. Kelly Graner. Following the presentation, Dr. Kelly Graner will join us for a live Q&A. Dr. Graner is a board-certified orthopedic surgeon with Franciscan Physician Network orthopedic specialists. She has additional fellowship training for the hand, wrist, elbow, and shoulder. She provides care for issues such as fractures, carpal tunnel, other nerve disorders and injuries, tendonitis, tendon lacerations, arthritis, and much more. Dr. Graner is a graduate of Ross University School of Medicine in Dominica, West Indies. She completed her orthopedic residency training at the Beaumont Health System and went on to complete a fellowship in orthopedic hand and upper extremity at the Medical College of Wisconsin. We hope that you enjoy this virtual presentation.
Hi, I'm Dr. Rich Makowicz. I'm an orthopedic surgeon, specialty trained in hand and microvascular surgery for Franciscan Physician Network. Thank you all for being here today. We're going to talk about some common hand conditions and other upper extremity issues that patients may have. I'm going to start things off today talking about one of the most common things that a hand surgeon sees, and that's carpal tunnel syndrome. For those of you who don't know what carpal tunnel syndrome is, it's technically called a peripheral compressive neuropathy of the median nerve at the wrist. Simplistically, what that means is the median nerve, as it traverses the wrist, gets compressed by an overlying ligament. And this can typically present itself in patients with numbness in the thumb, the index finger, the middle finger, and actually the thumb-sided portion of the ring finger. It can also lead to pain, and one of the most common complaints we see, and something that finally drives patients to physicians, is it frequently awakens them at night, and they will typically alleviate this by shaking out their hands. As the disease progresses, it can result in weakness of the hand, so particular thumb issues, and we can even see what's called motor atrophy or muscle wasting of the thumb. This commonly manifests itself in patients as dropping items and, like I said, difficulty with pinching or grasping or things along those lines. If caught early enough, conservative treatment is a perfectly rational thing to do for it, and early first-line treatment is often things such as bracing, avoiding provocative positioning or aggravating activities, and lastly, steroid injections can be helpful, particularly in people who have had symptoms for a shorter duration. We often see it in things where people have repetitive tasks or are commonly using vibratory tools. And again, avoiding those types of activities can often be helpful. For those people where conservative care doesn't alleviate their symptoms or get them to the place that they want to be, there is surgical treatment for carpal tunnel syndrome. And this has improved significantly over the past couple of decades and can be done in a very minimally invasive manner now, whether but via open incisions or endoscopic techniques. Often it can be done as simply under local anesthesia, almost exclusively in outpatient surgery, and people can return to function quite quickly. Another peripheral compressive neuropathy, and this is the second most common one that's seen in a orthopedic or hand surgery practice, is something called cubital tunnel syndrome. And if you remember, carpal tunnel syndrome primarily infected or impacted the thumb, index, and middle fingers. Cubital tunnel syndrome gets the opposite side of the hand, the ring and the small fingers. So people will feel pain along the medial elbow that radiates down into those digits. It also can cause weakness in the hand, and people commonly complain of a loss of dexterity in the hands. So things like snapping, turning a button on a shirt, tying a shoe, all of these things can start to present themselves in cubital tunnel syndrome. Even handwriting can start to look a little askew. It too can be treated conservatively. So things that avoid prolonged elbow flexion. As we bend our elbow, that funny bone nerve is the ulnar nerve, and that can get pinched in a tunnel there, again called the cubital tunnel. So if you can support it at night in particular, because this is when we don't really have control of the position of our arm, so something like a reversed elbow pad, a towel wrapped around the arm, or even a brace made by a therapist that holds the elbow straight can prevent these symptoms from occurring. Again, does that work for everyone? Unfortunately, no, it doesn't. Surgery can be done, and again, this too can be done in sort of a minimally invasive way through small incisions or even done endoscopically, which allows people to return to work and function quickly. So very often, carpal tunnel syndrome and cubital tunnel syndrome, again, are aggravated or caused by our activities of daily living. So for example, in cubital tunnel syndrome, if someone is resting on their elbow all day, so avoidance of direct pressure on the nerve, that can be very helpful. And same thing with carpal tunnel syndrome and ergonomic assessment, a better workstation design where you're sitting upright, looking directly into the computer, your elbows are at your side and at 90 degrees, avoiding essentially what's called provocative positioning of the hands. So frequent movements, and these are things that we do during the day. Long-term driving, switching from one hand to the other. These are things that avoid excessive positioning and can be very helpful for patients. Two, people who have carpal tunnel syndrome have a higher incidence of cubital tunnel syndrome as well. So one peripheral compressive neuropathy often leads into the others, and they tend to coexist. So just because you have one doesn't preclude you from having another one, unfortunately. Or even in that case, having it on the other side is also quite common. Both of these conditions can be treated in an outpatient setting and generally speaking under an hour. Certainly patients can call our office directly. We're happy to see people at any stage in the spectrum of how this disease presents, from early to the end stage. We're very comfortable taking care of all aspects of it. Some people do come via their primary care physicians or have had something called electrodiagnostic testing, which is a means of testing how the nerve functions. And these can show subtle changes in the nerve, and they're often referred to us that way. But either method, we're very approachable for all of these. If you're thinking about your hands' numbness and tingling more than a couple of times a day, or you're having to stop what you want to be doing, for example, like I said, driving, if you're unable to drive over long distances because, again, your hand's falling asleep, or if you're unable to sleep at night because it's frequently awakening you, any disruption in what I would consider your normal life or quality of life is a good reason to come be seen by one of us physicians. Now I'm going to turn things over to Dr. Tony Lin, my partner, who's going to talk about other common hand conditions.
I'm Tony Lin. I'm one of the orthopedic hand surgeons at Franciscan Health, and I'm here to explain a few more of the really common hand conditions that we see. We're going to start with a condition called trigger finger. Very, very common. Not a day goes by that we don't see this in the office. It's also called tenosynovitis, which is essentially tendonitis of the flexors or the tendons that bend your fingers. This really commonly starts with just pain in your palm. A lot of patients can identify a tender spot. And then eventually they notice that their finger is clicking or catching, and this is also called triggering, hence the name trigger finger. I call it a hitch in your giddy up, where the finger just doesn't move smoothly through its range of motion. Some patients, even in the morning, find that their fingers are stuck in a bent position and they have to really manually pull them straight, which can be really uncomfortable. It's common in almost any sort of demographic, but particularly in patients with diabetes or certain other inflammatory conditions, they can be more at risk for this particular type of hand condition. It's really painful with gripping, and again, if that finger is stuck in a bent position, really uncomfortable to unlock. We've got lots of treatment options for trigger finger, and we always start with things that don't involve surgery. So anti-inflammatories like ibuprofen or naproxen can sometimes give some relief. Some patients find that wearing a splint at night prevents that finger from locking when they wake in the morning. By the time they come into our office, they've probably tried a couple things or have symptoms that are bad enough that we will administer a steroid injection, which is kind of like the cortisone shot that you typically hear of. And that settles down a lot of the swelling and inflammation and can even resolve this condition without surgery. If the injections don't give complete relief, then surgery is indicated. And that is a really quick 5 to 10 minute procedure. This can be done under local anesthetic where you're awake and talking to us, or if you prefer to be asleep, we can certainly do that too. And then the triggering and the locking is immediately gone. You've got a couple stitches for about a week, but we have lots of patients who are able to go to work at, say, a desk job even the next day after surgery. So the trigger finger that I just mentioned is often confused or mixed up with a different condition called Dupuytren's disease that can look really similar. This is actually a hereditary condition. Now, it runs in families, but it's pretty unpredictable in the way it can run in families, meaning it may skip generations or some siblings may have a more severe version than others. And it also doesn't develop until later in life. Usually 40s, 50s, 60s is when we first see this. So I always tell patients you may have had family members who had this condition, but maybe didn't live long enough that it was noticeable or something that they complained about. In this condition, it's similar to the trigger finger in that you've lost some range of motion and the finger can appear that it's really stiff, but you've got nodules in your palm. And so the nodules are kind of the hallmark of Dupuytren's disease. They just look like little bumps and they grow really slowly. And then you can get some pitting where the skin has been pulled down, and then eventually a cord, which looks like it's the tendon, but it's actually in the layer of your hand above the tendon, closer to the skin. And this is the Dupuytren's material that runs in families. And it's not dangerous, it's not cancerous, it's really just some extra collagen that your genes have programmed you to make. And over time, that collagen, like any good scar, kind of contracts. And as it contracts, it can draw that finger down. We usually just watch this until you can't put your hand flat on the table. Then if your contracture has developed that much, it's time to get evaluated and see if you need a procedure or surgery. One interesting thing about this condition is that you can also get it in the soles of your feet. So we normally don't talk about feet much in the hand surgery clinic, but this is one time we might mention it. As I mentioned, once you can't put your hand flat, come on in to see us. And we've got several options for treating this. Some can be done in the office. There is a enzyme called collagenase, which is available commercially. And so we can inject that. Anything that ends with an ase is an enzyme. So this is an enzyme that dissolves collagen. So as we inject this, it dissolves the collagen of the cord overnight. You come back the next day and we numb up your hand and can manipulate this cord such that it's not contracting the finger anymore. And most patients can then lay their hand flat before they leave the office. There's another office procedure called a needle laparotomy, where we use the bevel of a small needle to cut the cord. And both this and the collagenase essentially cause a fire break where the cord's just disconnected, but you still have all the Dupuytren's material in your hand. If we have surgery for this condition, then we actually remove the Dupuytren's material so that the nodules and the cords aren't there anymore. And depending on the pattern of your Dupuytren's disease, you may be a better fit for one procedure or surgery than another, and it's better just to have that checked out to see what's the best for you. So another condition that causes lumps and bumps in the hand are ganglion cysts. So most of us have heard of these in the hands or other parts of the body, and ganglion cysts are benign, so not cancerous. They're little sacs that have filled with fluid, and they usually come from either the joint or the tendon sheath. So normal places that make fluid, like your joint or your tendon sheath, have made a little bit too much, or the fluid has found a way out. They're not necessarily painful, so they're not dangerous to just leave there and watch. So if they don't bother you, other than, aesthetically you've got a bump, a lot of times we don't have to do anything about ganglion cysts once we've confirmed that it's actually a cyst and not, anything more solid or concerning. We don't always know why they arise. It's not necessarily due to an activity or an injury, though sometimes they can be. Ganglion cysts of the wrist can be either on the back of the wrist or of your wrist. If they're on the back of your wrist, sometimes we can drain these in the office. But on the front of the wrist, we generally want to do surgery as a treatment because it's close to an artery most times. Now, mucus cysts are cysts that arise in the joints of the fingers. And commonly when they're at the end of the finger, they're related to arthritis in that joint. And because it's so close to the nail, they can cause some ridging in the nail or thinning of the nail, and a lot of times that can cause some problems for patients. So again, we can drain cysts depending on the location, or sometimes we take them out. And when it's related to arthritis, we'll often take out the bone spur, some of the arthritis that's right under the cyst. So we're often asked if this condition or the surgery would be covered under insurance. And typically when a hand surgeon is saying that you've failed or not responded to conservative measures, we document that, and the insurance companies will review that and typically cover it as a authorized procedure for surgery. However, the out-of-pocket is really dependent on your plan as well as the deductible that you've already met for the year. You don't necessarily need a referral to come see us. Lots of patients call us directly. However, it's good to know your insurance plan, as some do require referrals to make sure that you have the full coverage that you need, in which case you could always give our name to your primary care doctor and they can follow those referral pathways for you. We often get asked if physical therapy or occupational therapy is a good option for these conditions. Unfortunately, for these specific ones, they don't tend to alleviate the symptoms or the condition. With trigger fingers, we really need to just calm down that inflammation and shrink the nodule that's catching or triggering. And therapy may actually increase the pain until a steroid injection has a chance to work. Same with the Dupuytren's, is a hereditary condition. So therapy won't do much. I'll often tell patients just to kind of keep their fingers stretched back on a daily basis, but we don't recommend formal therapy to help prevent any symptoms from that. Not all patients require therapy after surgery. However, if you have a lot of stiffness prior to surgery, it can make the recovery a little longer. And so we often will send those patients to therapy to make sure you regain as much of your range of motion and your function as you can. If you do need hand therapy, Franciscan Health has certified hand therapists at both our Indianapolis and our Mooresville locations, and we can make those referrals for you. Thanks for joining us today, and I hope you learned a little bit about trigger fingers, Dupuytren's disease, and ganglion cysts.
Hi, my name is Kelly Graner. I'm one of the hand and upper extremity specialists at Franciscan Orthopedics. I'm going to be talking about some of our common hand conditions, including kind of focusing on the thumb. One of the most common things that we see is thumb arthritis, and typically mostly at the base of the thumb. This is also known as CMC, or carpal metacarpal joint arthritis, and this is one of the most common areas that we see. So arthritis, as we think of it, can be inflammatory or degenerative, but most importantly, at the base of the thumb at this joint, we typically will have pain and sense pain at the base near it, kind of in almost a horse shape, kind of U-shape like fashion. And that's just understanding that even though our joint is here, it's a three-dimensional shape structure and seems to actually be at the base of the thumb. So pain can come on with gripping, pinching, and so activities that use that, so opening a door, opening a jar or a can, those are things, and as well as kind of gripping with the thumb, can sometimes cause pain. So in addition, patients can also experience a weakened grip. So some of the conservative treatments, and first step is conservative. So we start with the easy things in terms of anti-inflammatories. Heat sometimes feels more soothing than ice, and then also some activity modifications. So sometimes using different openers for helping with cans, or sometimes maybe doing a different kind of position modification with certain activities. Some splints, some wraps, like an ace wrap can sometimes be helpful, and those are just easy things to try before maybe seeing myself or one of my partners. If pain persists, then sometimes there may be a role for a steroid injection. Sometimes that can help with diagnosis, but also can sometimes help in terms of treatment, may provide relief for a certain period of time. If that seems to fail as well as all other treatment options, then we may be focused with talking about surgical treatment. Surgery for this, there's a couple different ways to go about it, but basically we take out one of the bones in the thumb base, and that's mainly to allow for that kind of removing of that grinding surface where we're having that pain generator. Next up, we'll be talking about DeQuervain's tenosynovitis or tendinitis. And very similarly, as we talk about the base of the thumb arthritis being here, we tend to have pain along the wrist with the tendinitis. And so patients will have issues with kind of pain along that radial wrist and thumb, and so especially extension of the thumb. Some patients will know this or look up online and may notice a base of the thumb, or some people will talk about this as being a new mom tendinitis. And so important to understand, why do we talk about this? With a new baby, we tend to kind of cradle, also kind of holding and kind of lifting up a young child tends to aggravate those tendons. And so things that we notice is typically tenderness all along where those tendons run along the wrist and into the thumb. And then what we typically will test is called Finkelstein's maneuver, where we'll actually bring the thumb down into the palm, fingers around, and if that kind of with some ulnar deviation and kind of bringing that ulnarly, as seen in the slide, if that produces pain, then you might likely have that tendinitis. So what are the steps in treatment? So the first thing, as we talked about with the arthritis, is going to be conservative. What can you do at home to see if we can get this to go away? That includes anti-inflammatories, sometimes acetaminophen, sometimes putting a splint on to rest the tendons or rest the thumb. But if you're coming into our office, we're more than likely going to confirm, one, the tendinitis is present, and then also talk about maybe doing an additional steroid injection. Again, one potential intervention is that steroid will provide some diagnostic benefit, but then also may be therapeutic, may get it to go away. And so that sometimes may be something we may repeat, and then if it doesn't improve and things are failing, then we may talk about surgical interventions. Surgical intervention then involves taking the pressure off those tendons where they're getting pinched, where that inflammation is coming from. And so it involves a small incision and actually just taking the pressure, releasing those tendons. Again, this is basically a small subset on DeQuervain's tenosynovitis and that tendinitis in the radial wrist. So prevention is always something that we love to kind of employ if we can. Unfortunately, when it comes to either of these, there's not a great way to prevent. It's more of a reactive intervention. Now, that being said, with arthritis, we know of that as kind of wear and tear. So when we're talking about things, you can try to, at an early onset of symptoms, try to prevent the worsening by kind of catching it earlier on. So trying the anti-inflammatories, maybe using a splint or a wrap. But a lot of times it's going to be one of those, once we've started feeling the symptoms, then we've got to act on them if they're bothersome enough. Therapy has a very good role in many hand conditions, and we have a very good relationship with our therapist. I will say in the setting of arthritis, there is a limited role for therapy, and mainly because the joint is already somewhat degenerative. So when we start talking about therapy, typically the modes of therapy are really improving motion, but then also sometimes in terms of mobility. And unfortunately, when you have a joint that's not really healthy, sometimes increasing mobility can sometimes aggravate that arthritis or the symptoms. So there may be a role for it, but it may be limited. On the other subset, so talking about the tendinitis, there is some role for therapy, but again, limited. A lot of times the anti-inflammatory, the rest, as well as maybe a steroid injection may be more beneficial, but that may be some treatment option depending on what we see on the physical exam if you come in to see us. So in terms of therapy post-procedure, there is some role for splinting, there is some role for mobilization. Sometimes with surgery, we may notice swelling or certain scars that may be kind of becoming more adherent. There may be a role for therapy to work on scar mobilization, sometimes splinting, as well as swelling and decreasing, as well as increasing motion as we allow following surgery. Typically the best time to see one of us or come in and call or start talking about seeing a surgeon. So even though, yes, we do have surgeon in our title, most importantly we want to make sure that we can do whatever is best to get these conditions to feel better. So first thing you can start on your own, if it seems like these may be the conditions that you're seeing or feeling and sensing, then I would try the anti-inflammatories. Rest, see what activities that seem to bother them, try to lay off of those for a little bit. If it's not getting significantly better within a short time frame, and that may be, a couple weeks first if you're suspecting the tendonitis, it may be a couple months if you're suspecting the arthritis. If it seems to really not be getting any better and significantly bothersome with normal daily activities, then I think it's worthwhile to come and see us, because there may be other treatments, as we've talked about, that may be beneficial. Well, I'd truly like to thank you for tuning into our presentation. Hopefully that gives some of the quick ideas and tips and tricks in terms of things that you may be experiencing or someone that you know of may be experiencing. If you are seeking out more information, feel free to tune into our website at franciscanhealth.org, and feel free to see us at any point in time. We're more than happy to help and evaluate things and help treat if needed. Take care.
Thank you, everybody, for watching and listening to our common hand conditions presentation. It is now time for our second poll question of the day. And for this question, we would like to know, after watching the seminar, which topic covered did you find the most helpful? Carpal and cubital tunnel, trigger finger, Dupuytren's disease, ganglion cysts, thumb arthritis, and DeQuervain's tenosynovitis. Go ahead and choose whichever one you felt was the most helpful for you. All right, and it looks like thumb arthritis was the most helpful. So hopefully we'll get any other questions answered that you need. So thank you all for engaging in that question. If Dr. Graner is ready, I do believe that she's on the call with us. We can go ahead and begin answering some of your questions. Dr. Graner, can you hear me okay?
I can hear you well.
Thank you so much for joining us.
Thank you.
Our first question that came through the chat says, I had the classic carpal tunnel symptoms, which I think were caused by replacing a floor. When I completed the project, the symptoms still persisted for several months. The symptoms have seemed to cease. Should I be concerned for future issues or let it go?
So I think that's actually a really good, really great question. And I think it's helpful for others too. These aren't, we have to kind of remember that these conditions can be snapshots in time. So on one day, it may be significantly aggravated, but you may get to a point where it gets better. So doing an activity such as installing a floor, that's a lot of work. A lot of times you may be even kind of pushing, and even sometimes I've seen some patients or heard of some patients that are, kind of use their palm. Unfortunately, using that base of the palm and having a lot of increased activity at a short time frame can really aggravate both our tendons, but also sometimes in small spaces, tendons or nerves. And so you can have carpal tunnel, which it sounds like, as long as it was kind of evaluating or kind of infecting the thumb, index, middle, maybe ring fingers, that likely was carpal tunnel. And typically, if you give it time, rest, avoiding those activities, maybe using a splint, sometimes these conditions can get better. Now, the flip side of that, so if you are getting better symptoms, if all that numbness and tingling has gone away, you don't need to seek any additional treatment. However, I would be very aware that if you start having that numbness and tingling come back, it's not uncommon if you've had it before. Sometimes it can return. Sometimes it takes a different activity or doing something a little bit more strenuous. Sometimes it's just the fact that that space around the nerve just isn't quite available. So I would be aware to kind of seek treatment or start splinting again if those symptoms come back. But if the splint's not working or symptoms are persisting or worsening, definitely come back into, maybe come and see, one of us or, a hand surgeon.
Wonderful, thank you. So for carpal tunnel treatments, how long do you generally advise conservative treatments first? How long can someone expect to have to use some of those conservative treatments before having a procedure?
It's a great question. And everyone's a little bit different, and that's the biggest thing, I think especially physicians as well as surgeons, we have to listen to each patient. I have some patients who might be a little bit older who have mild symptoms, numbness and tingling comes and goes. It's not always there and maybe wakes them up at night. And I put them in a splint. And if they wear the splint at night and those symptoms go away, then they may just be comfortable wearing the splint at night. When I say we definitely need to kind of, seize conservative or stop conservative management is when that numbness and tingling isn't going away with the splinting. If it's persisting, happening more so throughout the day, or absolutely getting worse. If that numbness and tingling is constant in nature, meaning absolutely no relief where that sensation is normal, then I would definitely seek treatment quicker rather than later, because sometimes you can have some degree of permanent nerve changes if the nerve's not getting better blood flow. So again, kind of briefly, I would say sometimes it may be 4 to 6 weeks, and if the patients aren't getting better, then we might talk surgery. If patients are getting better with the conservative management, we can do that for a much longer period of time. I do have some patients that respond to bracing okay, but then after a period of time get tired of having to wear the brace at night. That's when that patient-specific kind of decision-making comes in, to where we may say, okay, well, maybe it's time for surgery. We get the pressure off the nerve and get you back to not having to kind of compensate for having symptoms.
Great. And the next question we have is a twofold question. So for a lot of these surgery procedures were mentioned for these conditions. How long do those surgeries take, and is a hospital stay involved, or are they treated as outpatient?
Very good question. Almost all of our surgeries that we do are treated as outpatient procedures, meaning come and go home same day. Most, I would say, are scheduled as elective procedures in our surgery centers. Some are done at the hospital for various reasons. Most are done outpatient. It's rare that we have patients stay in the hospital, and that would be sometimes more infection, if they have other things going on systemically. So more complicated issues, but I would say almost always they're outpatient procedures. Most procedures take under, sometimes like trigger fingers or carpal tunnel will take less than 15 or 30 minutes. Some fractures or arthritis procedures may take an hour to 2 hours. Really just depends on kind of the nature of the injury or the issue at heart to know what that timeline is, but it's rare for things to take much longer than that.
And how can a patient best prepare for a surgery? Are there things that they need to do ahead of time in order to be their best before they show up on surgery day?
Absolutely. So I think there's a couple of things that go into it. One is just making sure that you feel confident with your decision for surgery. And a lot of times with elective procedures, talking to your doctor, making sure you're asking all the questions that you have. There are no silly or stupid questions. The most important thing preparing for surgery is doing everything you can, gaining as much knowledge and as much comfort as you have going into that day. I always tell patients to ask all the questions that they can, because a lot of times that will alleviate some of the unknown or kind of lessen the anxiety leading into surgery. So first off, ask all the questions that you need. You should also feel comfortable and confident in who's performing the procedure, have a good rapport with them. The other thing is sometimes patients, it depends on your level of comfort. Some patients will actually go online and look up, what the procedure is. You can sometimes find the procedure online to watch. So everyone's a little bit different. And I would say go with what your comfort level is in terms of how much you want to delve into the actual procedure itself. The other thing is understanding and asking those questions of what the post-operative rehab, and what the recovery is going to be. That may be, is it going to be a splint for a week or more? Is it going to be immediate motion? Is there going to be likely therapy involved? So those are all good questions to ask, just so that you're aware of what the expectations are. Once we know what the plan is and a lot of what the expectations are, it really does help alleviate a lot of those concerns and makes it a much smoother recovery.
Great. And our next question is kind of along those same lines of recovery, is after a carpal tunnel surgery, how long does that affect the ability to drive?
So in terms of some of my patients, so if I and all of my partners as well, Dr. Lynn, Dr. Makowitz, will do carpal tunnel release we offer it awake, but numbed, kind of like the dentist's office. But we also will do under an IV sedation. But the patients that actually come with just the local anesthetic, being numb, awake, but like the dentist's office, those patients actually can drive themselves to and from surgery. So you can get back to driving as long as you feel safe and comfortable doing so right after surgery. I have some patients that have a little bit more kind of struggle in terms of discomfort, or sometimes just don't feel comfortable. And sometimes it can take a couple days, but as long as you feel comfortable, you can get back to it almost immediately.
That's good news, I'm sure, for people worried about not being able to drive. Well, I do not see any more questions on my end. I'll give a few more seconds for anybody to throw any other questions in there. But thank you so much, Dr. Graner, for being here. And it looks like one more might have come in. Okay, it says, you helped me tremendously by removing my, I don't know if I can pronounce this, but scaphoid bone and cyst. I don't have tons of pain at night. There is still often nerve-like pain, sharp pain on the opposite side of the thumb at the wrist. It only happens when I use it. Ha ha. I still wear a brace most of the time just because it feels better.
Okay. Well, I would say with that, if still having symptoms, by all means, come back in and see me. And that's the biggest thing after surgery. There are always different things that can come up. Sometimes we develop other, tendonitis or other stressors in the wrist. So if there is something that is happening, or you feel like there's something that's a little atypical, don't just think because a doctor has released you and said, oh, you're doing great, the fracture's healed, or you've healed great from surgery. It doesn't mean that other things can't happen. We have so many structures in the hand and the wrist. So if you're having any discomfort, by all means, come back in and see me. I'm more than happy to see you again.
She said thank you.
You're very welcome.
All right. Well, thank you everyone for joining us today. We really appreciate all the engagement. And thank you so much, Dr. Graner, again, for being here and answering all of our questions. It looks like we had one more come through if you have a couple minutes. He wants to know how to schedule an appointment. So I assume just calling the office is a great place to start.
Yes. So I think during the video, Dr. Lynn alluded to this. So everyone's insurance is a little bit different. You can definitely call my office directly, which is 317-528-4723. And again, any of my hand surgeon, my colleagues, we're more than happy to take care of you. If you have a preference, no big deal either. But if you call, they should be able to maybe look into insurance to see if we do need a referral status. There are some insurances that are very common to know that. And if that is the case, they may tell you, okay, you need to go talk to your primary care physician and then get that referral placed. That does not mean that you always have to go in and see your primary care physician before they'll place that referral status. A lot of times if you call with an inquiry and say, I'd like to see a hand surgeon, I've got something going on that I'm concerned about, they're more than happy to refer you to one of us.
Wonderful. And if that person wants your office to call them, I'm happy to set that up if he just wants to let me know if he would like to receive a call, and we can have somebody call you and get you set up for an appointment there. Let's see. He wants to repeat the phone number, but we can send out all that information in the follow-up email. We will also send out the recording to this presentation and the Q&A today. Along with that email will be a survey about today's event. And if each of you could take some time to fill that out, that would really help us make our future seminars better. We appreciate your honest feedback. So I think that those are all of the questions for today. I know I've said that a few times, but I do think that we have reached the end of our virtual seminar. So thank you everyone for being with us today, and have a blessed rest of your week.
Thank you for having me. Truly appreciate it.
Welcome. Bye-bye.